All right, hey guys, Rick Bigger. I'm going to walk you guys through the Levophed protocol. This is the continuing education for the month, so make sure that you fill out a 1085 and get it sent to your shift rep so that you can get credit for the class. If you're watching this, if you're just watching the video as a crew, then make sure that you mark that this is distributive education in the boxes on the top right of the page. If you are an instructor and you watch this and then reteach it, and there's a live instructor in the room, then you do not mark that box. And make sure that you select which one it is so that we can get you the proper credit on your research. So, all right, this is straight from your protocol app on your phone. If you go to formulary and then roll down to norepinephrine, this is the page that you will see if you like to look at it that way. So I'm going to read through this and then break some of this down to layman's terms and talk about it a little bit, and then we'll go through the dosing chart. And then I'm going to attach a second video onto here at the end, which will show you how to actually mix this into the bag and then show you an easy way to remember the drips for your most common dosages. All right, so starting at the top, we have norepinephrine, also known as Levophed. This is a vasoconstrictor. So the actions of how this works, it stimulates the alpha receptors in the peripheral vasculature, producing vasoconstriction-related increase in systemic blood pressure. Concurrent beta receptor stimulation may produce increases in heart rate and mild bronchial dilation, though norepinephrine is a weaker beta stimulator than dopamine. So what does all that mean in layman's terms? For us, all that matters is that it's a vasoconstrictor, and it raises the blood pressure. The other thing on the end of that, the thing to remember with norepinephrine, one of the benefits of it is that it doesn't increase the heart rate as much as some other of the vasoconstrictors, such as epinephrine, does. So that's good, because that's not what we're looking to do. The indications for Levophed: dyspnea for CHF, post-cardiac arrest treatment, ACS, fever, in particular sepsis, and dialysis-related issues. These are all talking about adults. For all listed situations, indication is hypotension. So in adults, a systolic blood pressure less than 100 due to cardiogenic, septic, or neurogenic shock, either refractory to IV fluid bolus or in which IV fluid bolusing is contraindicated, such as pulmonary edema. So once again, layman's terms, we can use this for a patient that has CHF, that we don't want to give fluids to, or dialysis-related issues. So we don't want to give somebody more fluids because they already have too much fluid in their lungs or too much fluid in their system, but we need to bring their blood pressure up. The others, post-cardiac arrest treatment, we've already given a lot of fluids, and it's not working. The patient's not responding to it. They have low blood pressure. We can bring their blood pressure up with Levophed. ACS, same thing. They're having a STEMI. We're giving them fluids. It's not working. We can use Levophed to raise their blood pressure. And then sepsis. Same thing with sepsis. We have massive systemic vasodilation, so we're going to reverse that with Levophed. We've already given them fluids. It's not working once again. So dyspnea and dialysis, or CHF and dialysis, we don't want to give fluids because it's contraindicated. The others, we're already giving fluids and the hypotension is returning, so we use Levophed. The only contraindication listed is hypertension. Obviously, if we already have hypertension, we don't need Levophed. So the thing with Levophed is the onset of action is within 5 minutes after IV-IO infusion, and then it's rapidly metabolized, which requires ongoing infusion to maintain the clinical effects. So that's why we use it. It works quickly and it burns off quickly. We use it, we don't need it anymore, it doesn't hang around, so the thing to remember is once you turn that off, the effects are going to go away pretty quick. Side effects of Levophed: there's a few at higher doses. Symptoms may include headache, palpitations, tachycardia, chest pain, and eventual hypertension. Bradycardia can result reflexively from an increase in blood pressure. Something to remember with Levophed: the bradycardia is not that uncommon. You may use Levophed and then get bradycardia as a result. So it's something to look out for and monitor, especially in post-cardiac arrest treatment. If the patient is already bradycardic and we're using Levophed, that we don't lower the heart rate too much. So it's when using Levophed, that's something that we're always monitoring. So how do you dose this? Levophed is very easy to dose. We use the same dosage for all the different problems. Reading down to the bottom there of all the different, once again, all the protocols listed that we can use it for. It says start for 2 to 4 mics a minute and titrate to a systolic blood pressure of 100. The maximum infusion rate is 12. Then we have the chart. It shows us the drop rates per minute for each of the doses 2 through 12. And we're going to get back at the end. Like I said, we'll get back in just a minute to how to do that easily. If you read through that, we have 2 mics a minute, 15 drops, up to 12 mics a minute, which is 90 drops a minute. We'll talk about easy ways to remember those and which one of those are commonly used. Let's flip over to the second page of the protocol, and you see the protocols listed again. So the dosages for these protocols, these are for pediatrics. Okay, so the dosage is going to be the same, but you'll see at the bottom there are 2 stars, on-loan med control order only. So anytime that we use Levophed with a pediatric patient, and we're going to, we have to get online med control order first. And it's always a great idea if you already have med control on the line. Once you talk to that doctor, tell him the way of the patient and ask for a recommended dose from the doctor. Tell him what your protocol is, tell him what it says, and then get the dose that he would like you to use if you already have him on the phone. Just something to think about. So how does this come supplied and how do we mix it? Right there next, it comes in a 4 milligram per 4 milliliter ampule or vial. So we know it comes in a little grass vial, and I actually have that on the next video. You'll see there in bold and underline. If you ever forget this, it's quickly in your phone to be able to find. It's there for a reason. It says use only 2 mils in a 250 milliliter bag of D5W. Right, so the thing to remember about Levophed, the reason that you use it in dextrose, it says this down at the bottom, avoid mixing in normal saline, as normal saline promotes loss of potency through oxidation. That's really for the hospital long term. It's not really going to happen in the setting that we use it in, the amount of time that we use. But we want to mix this with D50, with dextrose if we can. The concentration of the dextrose, it doesn't matter as far as it can be D5, it can be D10. We carry 250 milliliter bags of D10 that we are now using. They're in every IV bag, or that we use it for every diabetic call, for hypoglycemia. So we have the 250 milliliter bags of dextrose that are there to use. If you use one of those, we're going to take half of the vial and put it into that 250 bag. If you don't have that available or you can't find it at the time, no big deal. You can put this into a 500 milliliter bag of normal saline because we're going to use it in the next 10 minutes anyway, and it's never going to have time to oxidate. That is okay too. It's preferred that you use dextrose. If you notice it says avoid, it doesn't say that you can't, it just says avoid. We want to use it in dextrose, but if you need to use it in a 500 bag of normal saline, that's completely fine. But obviously that's a 500 bag, so if you're going to mix it into a 500 bag, you're going to use the entire ampule because it's double the amount of fluid. So no matter which way you do it, whether you put half into the small bag or you put the full vial into the big bag, it's going to come down to a concentration of 8 micrograms per milliliter, and the dosages are going to be the same. All right, so through our special comments, in the settings of tachydysrhythmic induced cardiogenic shock, treat per the protocol 5G, tachycardia unstable. Ensure aggressive fluid resuscitation is accomplished unless contraindicated prior to norepinephrine use. All that's telling you is that if you know the cause of the hypotension is unstable tachycardia, then treat the tachycardia first and make sure you give fluids prior to giving Levophed. For us, most of the time, there could be a case where we're going to give Levophed, such as CHF or such as dialysis, but in particular, if we know the tachycardia is what's causing the hypotension, treat it and then consider Levophed if it doesn't work. But we're pretty much always going to fluid resuscitate before we give Levophed. So next, norepinephrine should be given in a large patent vein. the vein of choice for EMS use is the AC, as it will decrease the risk of overlying skin necrosis. Do not administer norepinephrine through an IV in the hand or the leg. These veins are more likely to be affected by vaso-occlusive diseases and more prone to ischemic complications. Administered through the IO in the proximal tibia or humeral head is permitted. So you can give this to the IO. It is preferred, and it moves a lot easier if you give this through a good IV. So what that really means for us in layman's terms is after you get ROSC and a cardiac arrest is when we're going to use this the most. So after you get ROSC, get an IV and give the Levophed through the IV. It flows better. It's easier to control. It is next to impossible to use a pressure bag to push it through an IVO and control the drip rate. So you need to start an IV. It needs to be a large bore IV, and it needs to be in the AC, really, to give Levophed effectively. So once you get ROSC, that should be, and once you go down the line, you're checking your ABCs, you're ensuring that your airway is still good, you're ensuring that your breathing is still good, your ventilator set up properly, and next is your circulation, right? So that's when we find that we have low blood pressure, and we've already given 500 bag through the IO. That's when we should be starting a good IV and starting a drip of Levophed with some more fluids. You can give it through the IO, next to impossible to ensure that the drip rate is right. So let's get IVs and let's give it that way. If local extravasation occurs, notify the receiving physician of the following FDA announcement. Do FDA advisement of antidote for the ischemia. Okay, we're not going to tell a doctor that in the ER. If you know that IO is bad and you put Levophed in there, let the doctor know that happened, and the doctor will be able to treat them, and they will know the proper route. Safety in pregnancy not firmly established, though when clinically indicated, the benefits outweigh the risk. Safety in pediatrics not firmly established, and online med controls be consulted prior to pediatric use. So what's that telling us? If you need to use Levophed on somebody that is pregnant, the benefits outweigh the risk, so we can use it. And if we're going to use it in pediatric, as said before, we need online med control. It wouldn't be a bad idea on somebody that was pregnant to get online med control for that as well. Never forget that if you're unsure about the safety of something, you're unsure exactly whether or not you can use the drug on that person, we always have online med control. And the very last there, avoid mixing in normal saline, as normal saline promotes loss of potency through oxidation and norepinephrine. Matt Nicholson did some great research on this about why we have that, and we discussed changing the protocol so that distinctly says that, and that will probably happen in the future. So far we have not, but we know that normal saline does not oxidize norepinephrine for a long time, so in the setting that we use it, you're perfectly fine to mix it in normal saline if you don't have dextrose available. If you have dextrose available, go ahead and use it. So that goes through the protocol. Review it about Levophed. If you have any questions about Levophed, I'm going to leave you with one more thing, and then you're going to have a next little video here that this will transition into, which is going to talk about how to mix the Levophed into the different bags and how to use the 60 drop with a demonstration of how to get your drip rates. And a really easy way to figure it out on the fly. Talking about administering this with the IV versus an IO in a large patent vein, how important that is. We're going to need to move a lot of fluids if the patient is hypotensive. Okay, you're going to need an adequate fluid bolus first. Really, per ACLS, what they want you to do is give a person 1 liter of fluid before you switch to Levophed. We're not held to that exact standard that has to happen, but that's really what we're looking to do. In order to move that liter of fluid in a decent amount of time, you're going to need a large patent vein. So remember your flow rates. So a perfect world IV for a 22 gauge IV will move about 30 milliliters a minute. So it's going to take 7 minutes and roughly 7 minutes to move 250 mil bolus. If you hear that traffic that's on this video, that's not at your station, so you can ignore that. Back to the IVs quickly. So I need to move a 250 milliliter bolus if you find low blood pressure, at bare minimum, right? So we're going to move that bolus. If we start at 22, in order to give this Levophed, it's going to take 7 minutes to move that wide open. Okay, so if you're pushing a foot bolus before you give the Levophed, even to push 250, it's going to take you 7 minutes to do that, do a 22. The IO moves about 50, so it takes about 5 minutes to move that. A 20, it takes about 4 minutes. An 18, it takes 2 minutes. A 16, 1.5. A 14, 1. So you see those dramatic numbers. If you can get an 18 gauge IV in the AC, you can move a lot of fluid in 2 minutes. You can move an entire 500 bag in less than 5 minutes. So that's really what we're looking for, is a good large bore IV in the AC vein. And you're going to see from the demonstration, with the dosing that you're about to transition to, it is a lot easier to control the drip rate on the 60 drop set if you have a large patent IV and there's not a lot of resistance. So guys, thanks for watching this review. Stand by and we're going to transition to the next video, and we'll go through all the dosages and how to get some nice easy ones to remember on the fly. So finishing up on our Levophed protocol review, we're going to go through how to mix and dose the Levophed and do a little demonstration here. So with Levophed, we have 2 ways that we can mix, starting with 2 mils in a 250 bag. The second, if the 250 bag isn't available, is we can mix 4 mils into a 500 bag. So per the protocol, they recommend that you use dextrose and you mix it 2 for the 250. So what you're going to end up with, this is your vial. So it comes just like this. You see you have 4 milligrams per 4 milliliters. So we're going to take half of that if we're using the small bag, and we're going to put half of it in there. If we use the full larger bag, then we're going to put the entire vial in. So after we go through mixing, we'll talk about the common dosages. So per the protocol, you can go 2 to 12. The ones we're going to focus on are 2, 4, and 8 because they're easy to remember. You see all the drops that you have there. Once you exceed 8, the drops come more than 1 a second, which is extremely hard to calculate. So we're going to focus on 2, 4, and 8, which are easy calculations. 2 micrograms is 15 drops a minute, which works out to a drop every 4 seconds. 4 is 30, which works out to 1 drop every 2 seconds. And 8 is 60 drops, obviously 1 second per drop. So we're going to move down here real quick. So you have our 2 different bags that you'll see. You have the one on the left here is dextrose, it's a 250 ml bag, and the one on the right is our normal saline 500 bag. So as I said, if you're going to use this 500 bag, which is what we're going to do whenever our dextrose isn't available, if you use the 500, this entire vial goes into that bag. So you break that open, draw your liquid out, and it goes through that port right there is where we inject into our bag. On our 250, same thing, we're using half. We use half of the Levophed, and we draw it up, and it goes through this port, just a needle port through the bottom, and you shoot the Levophed into your bag. And we always use a 60 drop, and you can tell this is a 60 drop. It's on the package, it says 60, but on a 60 drop, you'll look inside and you'll see the little needle sticking down where the drops are coming out of. On a 10 drop, you won't have that needle. It's not as pronounced as it is on the 60 drop. So on our 60, if we want to start with 2 micrograms a minute, that's a drop every 4 seconds. So you'll notice here, I have this set up. We have a drop, 1, 2, 3, 4. We'll get a second drop, 1, 2, 3, 4, get a drop. We're going to put that up to 4. If that's not working, we're not getting the desired result, I open it up a little bit more, drop, 1, 2, drop, 1, 2, drop. So that is now 4 micrograms a minute. And if we want to make this 1 a second to go to 8, 1, a little more, a little more. We're going to have a pretty consistent drop, 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 drop with no pause. So that right there is 8 micrograms a minute. So if you've never done this before, Pretty easy to calculate if you stick to those. When you exceed that dose and you go beyond 8 drops or 8 micrograms a minute, it gets hard to calculate because the drops are so close together. So you're going to have to count the drops, each one of the drops. So for me, I stick to 2, 4, and 8. If I have to go beyond that, you really need a pump to do that accurately. But right there where it's just consistent, drip, drip, that's 8 per minute, which is a pretty good dose of Levophed, and it's effective in most situations. All right, the thing to remember with Levophed also, when you're talking about using your 60 drop, is that, it says in the protocol to use a large patent vein. You need a pretty good size IV to make this easier on yourself. If you use a small IV in a smaller vein, it becomes harder because you have more resistance, and it's hard to keep this consistent. On a large vein with a large bore IV, a 20 or larger, this right now is hooked up to a 20, it allows the dosage adjustment to be easier because it's easier to control because you have less resistance on the end. You'll notice from my dial here, I'm not fully wide open here. I'm less than halfway open. So I'll give you an idea of where to start. If you open this wide open, you're gonna get a lot pretty quickly. I have this stuck into an orange on the bottom here to give me some resistance. When I open that wide open, it's jammed in there with a lot of resistance. So even though that's all the way open, there's really no way for me to exceed 8 micrograms a minute because I have too much resistance on the end. If I move that IV to simulate pulling it away from a valve, and I open it up there, it'll be a solid stream like that. There's no way for me to have any idea how much I'm giving. So it's much easier. If I have a large IV, it's much easier to do my calculations. Just something to think about whenever you're starting IVs for Levophed. You have to give this through a large patent vein. It is allowed to go through the IO, but just remember that the IO is basically the equivalent to a 24 gauge needle as far as how much fluid we can move. And I have to use pressure, which makes it impossible for me to control that rate. So we want to start an IV when we give Levophed, preferably a large bore, to make it easier on ourselves so we can do our calculations. If you have any questions about how to mix or dose Levophed, give me a call and we'll get it worked out. Thank you.